ladies. Okay, we'll just wait for more ladies to come online and then we will start our talk for today. Hi everyone. Okay, just a few more minutes and then we will start. Okay. All right, so hello everyone who has joined us. Okay, today's talk is with Dr. Kelly Loy from Mount Elizabeth Fertility Center. We're very excited to have her today for the topic of maximizing IVF outcomes and MACS Annexin. Okay, she will explain further what MACS Annexin is. All right. Before we start the talk, okay, we just want to make sure that everybody knows that even though we do have a doctor on board today to give us advice, everybody's situation is unique. So therefore, it is important to seek out the advice of your own doctor before you go ahead with anything. Okay? All right, so with that, I'm going to invite Dr. Kelly to come online. Hi.
Hi, hello. Hi, Kim.
Hi, nice to see you. Okay, great. Okay, can you hear me? Can you hear me well?
Yeah, very good. Yeah, very well.
Fantastic. Okay, all right. So, before we start, okay, we're very happy that you joined us today for this very interesting topic. Would you like to maybe give us an introduction of yourself before we start on the topic?
Sure. So hello, everyone. I'm Dr. Kelly Loy. I work at Mount Elizabeth Hospital and currently the medical director of the Mount Elizabeth Fertility Center. And I'm really happy to be on this program today. I'm very proud of the Fertility Warriors support group. Yeah, it's fantastic that they've come together. It's great that patients are have more information and can make better informed decisions. Yeah, on this important journey, fertility journey.
Thank you. And we're obviously very happy that you come on board. Basically, information or talks like these are very important for our followers because they give everyone a bit more information and basically on what they're going through as well. Okay, so let's go straight in. Okay, first thing first. So you mentioned that you're from Mount Elizabeth Fertility Center.
That's right. Yeah.
Okay. Would you be able to maybe share with us? I mean, this is definitely a question that a lot of people like to ask. In terms of your clinic, what are the live birth rates for women over the age of 35, over the age of 40, whether 2019 or 2020?
Okay,
I
so
know you have a slide, right? Can you
yeah,
just...
so it's actually quite timely. This is quite a timely question because we've just recently held our usual quarterly meeting on our success rates. And
Okay.
you can see on the screen, these are the latest figures from 2020 last year. So there were over 250 fresh cycles, in which refers to the egg stimulation cycles. And from these cycles, the fertilization rate was 71%, of which after fertilization, almost half became blastocysts, day 5 embryos. So this is the blastocyst rate you see here, 47%. And then looking down the rows, you can see now the frozen embryo transfer success rates. So in the age group of interest, for those over 35, the pregnancy rate was 66%, and for those over 40, the pregnancy rate was 30%. Over 45, the Ministry of Health now has allowed IVF to also be done. So hopefully we'll see some positive figures, but it's still early days. Of course, the highest success rate would be in the youngest age group, under 34.
Understand.
So the important question is, what is the live birth rate? I would expect the live birth rate to be around 10 to 15% lower than the pregnancy rates. We don't have the actual figures yet. They will be coming up towards the end of the year.
Okay.
But usually they would be around,
10 to
15% lower than the pregnancy rates.
Interesting. Those are pretty high rates basically for the clinic. Okay, in terms of your clinic, okay, there's so many private IVF clinics out there. There's also government hospitals out there doing IVF. How does your clinic actually differ from the other clinics or even a public hospital?
So, I would like to think that as a private clinic, we are able to provide a more personalized approach towards the patient's treatment. So from IVF preparation to the actual treatment program, we'll be able to be more responsive to the treatment requirements. Also, we have very strong laboratory support from the Mount Elizabeth Fertility Center. Yeah. So as you could see from the chart, we focus mainly on frozen embryo transfers because our freezing and thawing techniques are so reliable now. The thaw survival rate for our blastocysts is literally 100%. So by freezing our blastocysts first, we can concentrate on optimizing the lady's uterus and endometrial lining and conditions, so that we can then try to focus on getting the best pregnancy success rates.
So unlike other private clinics where they sometimes they have to use like somebody's IVF center or whatever, you guys have your own IVF center.
We work very closely with the Mount Elizabeth Fertility Center. Yes, so the laboratory support there is great. The embryologists are very dedicated, and also recently there have been new developments. So we now have on board an embryoscope, high technology embryoscope. So this allows the embryos to be monitored more precisely in a controlled, stable environment. So by using an embryoscope, we hope to be able to analyze the embryos better so that we can choose the best embryos for transfer and hopefully get better results from the
So an embryoscope is basically when they fertilize the eggs and then so they can constantly keep an eye on them. Is that right?
Correct. Exactly. That's it. You're right. Yes.
Are you located? Okay. Somebody was asking, Mount Elizabeth, Novena, or Orchard?
I'm at Orchard.
Orchard, and the facilities are also at Orchard, right?
All at Orchard, yes. So that's one of the advantages because it's in a hospital environment. So we have the theatre, anaesthetists, always
everything's nearby.
In case there's any complications. Very rarely do they occur, but at least it's a safe environment to be working in.
Just in case. Fantastic. Okay, I think today's topic, is maximizing IVF outcomes, and is it MACS Annexin or MACS Annexin?
So it's you can call it either way. I usually refer to it as MACS Annexin. So so MACS Annexin, well, MACS stands for Magnetic Activated Cell Sorting System.
Ah, okay.
So it's very interesting. It works on the basis that abnormal apoptotic sperm express certain proteins on the cell membrane. So through these proteins, the MACS annexin system is able to identify the abnormal sperm, and they are magnetically labeled.
Wow.
So by passing the sperm preparation through a separation column located in a magnetic field, the abnormal sperm are retained in the column, whereas the healthy unlabeled sperm is able to filter through, and then those healthy sperm can be then used for sperm selection for fertilization.
Interesting. So this is done obviously before fertilization, just on the sperm first.
That's right. So, sperm selection is actually very important. So, in order to get good IVF outcomes, we need both healthy eggs as well as healthy sperm. Often, we know that in terms of egg numbers, the numbers are going to be limited. For most women, we can get 10 to 15 eggs if depending on the lady's age and medical condition. So 10 to 15 is actually a good number of eggs to collect. Men, on the other hand, we know that they produce millions of sperm each time. So very often we take it for granted that there should be sufficient sperm to use for fertilization. But many couples facing fertility actually also have this problem of sperm quality issues, and it is also important to be able to identify the most healthy sperm for fertilization. And if the sperm quality is bad, the normal sperm selection techniques may not be specific enough. So this is where all these additional techniques and devices may be very helpful.
So in terms of, I know that there is another slide that you have. This slide here. So would you like to explain further about this slide?
Yes, so we've only, the lab has only started using this MACS Annexin system quite recently on a few selected cases. So it's still early days, but I asked them to help to collate some figures. So here we have some outcomes from our IVF cycles. So the fertilization rate in the control sample without the use of the MACS Annexin system, the fertilization rate was 70.3%. So with the Annexin system, MACS system, it went up to 72.6%. The blastocyst rate was also slightly better. It increased from 48.7 to 50.4. So, it's still really early days, but there is a trend towards maybe better fertilization and blastocyst formation.
Understand. So comparing it to some like ICSI, is there a big difference between, ICSI, does your fertility center offer both, or how do you know what to, basically for this couple, you should go through MACS or ICSI?
That's right. So PICSI stands for physiological ICSI. So it works on the basis that healthy mature sperm can bind to higher luronin or higher uronic acid. So PICSI can therefore be useful in identifying such sperm that can bind to the higher uronic acid. And in terms of benefits, these two devices are both available, and they can be offered at the patient's request. And from our point of view, though, we do recommend based on more the patient's semen analysis. So if there was a poor sperm binding assay to higher uronic acid, then perhaps PICSI might be useful. The studies have been, the results have been variable, and so not everyone might need or benefit from it, but there are some who may who may help where PICSI is used. MACS, on the other hand, also is very helpful in sorting out the abnormal sperm in general, and it sounds like it's very easy to use. And so studies also have found very promising results in terms of fertilization, blastocyst formation, and hopefully, we hope to see even better pregnancy rates and hopefully lower miscarriage rates. So personally, I have I would like to share 2 case studies involving couples who have been seeking treatment. So just to illustrate to you, 2 couples. It's a bit of the.
Is it okay? Can you see?
Yeah, it's a bit small, but if you kind of focus a bit, I think.
Okay, just before we go into this, right? Somebody just asked, does sperm motility also mean sperm quality?
Yes, sperm motility is of course also a good sign of sperm health. However, it is really more crucial for natural fertilization and IUI success. So for IVF, it is, I would say, not so crucial, although it would be preferable, but it is still possible to fertilize eggs with immotile sperm actually, and our embryologists will have more data, but I think it is still possible to fertilize eggs with sperm which are not so motile.
Okay, understand. Okay, so we'll go into the case study.
Okay, so this is a couple. Now let me.
Okay, so 39-year-old, the wife is 39 years old, husband is 55 years old, and obviously they've been trying to conceive the last 2 years. Okay, so they've had 2 spontaneous pregnancies resulting in miscarriage. Also, they did get pregnant twice.
That's right. Yeah. So they did get pregnant spontaneously, but unfortunately, both times they had miscarriages.
Understand. So, okay, her ultrasound was normal, AMH 10. Okay, AMH 10, is that a good AMH for a 39-year-old?
It is normal low, normal towards the low end of the range.
Okay, and his sperm count was 9 to 15 million per milliliters, motility 12%, and normal morphology 1%. How is that? Is that a good morphology?
So it's a bit low. So ideally, normal morphology should be more than 4%.
Yep.
So if the normal morphology were less than 4%, it's considered on the low side. So if it's less than 2%, 1 to 2%, I know that is really quite low, considering that the numbers are also on the low side.
Understand. Okay, so she did 2 cycles with you, one with Annexin and one without. Okay, so what we can see here, December 2020, ovarian stimulation 11 days. Okay, so both times that she did the stimulation was for 11 days, right? So during the oxide retrieval, so the first one without Annexin, she had 8 retrieved and fertilized 4. Okay, so 7 was obviously
7 were mature. 7 were mature eggs that were injected with the sperm. So the fertilization rate was 4 out of 7. So 4 out of the eggs that were injected fertilized and became embryos, but none of them developed into blastocysts.
Okay. And then
on the other hand, when we performed IVF again, as you read out earlier, in January 2021, she underwent 11 days of stimulation. This time we managed to get 12 eggs.
12, wow, okay.
Yes, and all 12 were good mature eggs. Wow. And we applied the MACS Annexin system for sperm selection, and the fertilization rate was 75%.
And she got 3 blasts.
Yes, and the good thing is that she had 3 blastocysts out of this cycle, and they were not bad at all. 3 AA, 3 VA.
Looks good, that's right.
So much better than the first cycle.
Okay, and then the next one is this one here. So this one, the husband's age was a lot younger. So instead of, just now was 55, this one was 37. Trying to wife is 38, trying to conceive for 1 year, while 4 times IUI failed. Okay, so she's had some small fibroids. AMH was also 10. Okay, and
so again on the low end of normal.
Yes, which is quite normal for that age, right?
Yes, that's right. You're absolutely right. Yeah.
Understand. So sperm count, okay, motility 2%. His morphology was a bit better. Okay, so also did 2, both in the same year, January 2021 and March 2021.
So, yes, very recent. So again, we can see here in the January 2021 cycle, the font here is a bit larger so I can see.
Okay.
Thank you for
Alright.
reading out earlier. Okay,
No
so
problem.
after 11 days of stimulation, we managed to get 9 eggs, of which 5 were mature. So 5 of these eggs were injected with sperm, and 4 out of the 5 fertilized. Yeah, but only one developed into a blastocyst, and it was a very average grade blastocyst for BB.
Okay.
Subsequently, when she came back for another cycle in March, after 10 days of stimulation, I managed to get 4 eggs. So not so many, but all 4 were mature, and all 4 fertilized after using sperm from the MACS and Annexin system. And
Wow.
and
And she got 3 good
really
blasts.
amazing, 3 good blastocysts this time.
Okay.
4 AA, 3 AA, very good grade quality blastocysts.
Wow. Okay.
So
In
these are
terms of
just 2
definitely very
examples.
good. Yeah. Definitely. I mean, both these does show that with the MACS and Annexin, it does seem to really make an improvement to the blastocyst rates, right?
Yes.
Yeah.
So I'm sure there might be other factors as well, because with the second cycle, we may be tweaking things a little bit better, giving her vitamins to help improve the egg quality. So there might be other variables, of course. It's not only just probably the MACS system, but overall, the results are promising, and we hope that it will give us even better rates in the coming future.
Right. That's very interesting. So, okay, when we come back to MACS and everything, in male semen, just now you did mention that count is not as important in IVF.
Motility.
Right?
Motility
is
motility
important or it's not important?
Not as crucial in IVF as compared to IUI. In IUI, we need a high percentage of motile sperm.
In terms of, let's say, if a couple comes to you, what test would you actually make the husband do to test his sperm to make sure that basically before they go ahead with an IVF cycle?
Yeah, so we would usually send him for a standard semen analysis to look at the sperm count, the quality, and of course the motility. So these are 3 important variables. But I do also send some men also for further detailed analysis. So we look at the DNA fragmentation index as well as the hyaluronan binding assay, which we discussed earlier with
OSA, right? Yeah.
So
in terms
of things.
Okay. So how, just now you said you send some men. How do you decide who to send? Should everybody just go for it, or how does that work?
Yes. So I would look at the history. So how long they've been trying, have they failed IUI before? And also the initial semen analysis. If the results are all very good and the report is normal sperm, then I don't necessarily feel that further analysis will be needed. But if I'm trying hard to decide, should we encourage them to keep trying naturally, go for IUI, or whether I should push them towards IVF earlier, then I think all these further details will be useful.
Understand. In terms of, let's say, if there's a male with sperm DNA fragmentation issues, is there anything that can help him?
Yes. So this is quite a common problem nowadays. In most cases, I would suggest healthy diet, fruits and vegetables, things rich in antioxidants. If you smoke, stop smoking, adopt a healthy lifestyle. And I do prescribe vitamins to help improve the sperm quality. There are some studies, which have shown that there might be some improvement, but not all men, experience the same benefits, unfortunately. So the treatment with antioxidants is, not foolproof. So in severe cases, I would sometimes refer to the urologist for co-management. So the urologist will help to assess whether there might be other medical issues or varicocele veins which need to be treated surgically. So sometimes, treatment might help under the...
So sometimes it's just not so simple as just taking something.
Exactly, that's correct, yeah. And in really severe cases, sometimes the urologist even offer testicular sperm extraction.
That hurts, right? Not so simple.
We try to avoid it. Yeah, we try to avoid it. that. Yeah.
Okay, somebody just asked, in terms of vitamins for sperm quality, is there any vitamins that you would share with us to say that you'd suggest?
You know, there are actually many on the market, you know, as long as I think you have one which has been, you know, designed for male fertility, I think it should be fine. Of course, we have our own that we always prescribe, but I would say, you know, something with a mixture of carnitine, CoQ10, vitamin E, zinc, selenium, you know, something like this should help.
Understand. So best to ask your doctor, and your doctor will prescribe it to you.
That's right.
Okay, in terms of, so we had somebody ask us about AMH. Okay, so just now, I mean, we obviously talked about these two ladies who were around the age of 37, 38, and they were a low normal in terms of their AMH. Okay, what would you say is a normal AMH level for, let's say, a 30-year-old, and then what is considered low normal? Is there certain rates?
Yes, actually there is a range. So in fact, you know, since I'm in clinic, share with you what I normally show patients. So maybe you can refer to this. So as a lady gets older, I'm not sure you can see this here. As a lady gets older, the AMH level will drop.
Wow, okay. And after what age will it drop drastically? 35?
So usually after 35, yes, that's right. 35, it drops quite drastically. So I will use this diagram because there's no fixed number really. There is a range for each age group. So as the age range increases, the AMH range also drops.
Correct. Because I remember at NUH, when I did my AMH level, they said, oh, it's normal. And then you go somewhere else and they say, no, it's low. So it's always very confusing with their different diagrams that they use. So
different ranges as well. So the diagram is you know, what I use all the time.
That's good. In terms of increasing AMH level or egg quality for a lady who basically has a low AMH, I mean, is there anything we can do to increase it?
So very unfortunately, women are born with a fixed number of eggs. So there's not much we can do to alter our AMH level. But in terms of egg quality, I think, you know, again, what we can do is to try our best to eat healthy, observe a healthy diet, lifestyle. If you smoke, stop smoking. I actually do prescribe supplements to many patients because I've seen them help many women. So again, the usual bunch of antioxidants, CoQ10, yes.
Understand.
Vitamin B complex also, you know, I find them really helpful.
Understand. Do you get the ladies, so would you just prescribe them straight away after they have a low AMH, or would you do any extra tests? Because I know that some people will say, oh, you do need to do I need to do a vitamin D test, you know, all those kind of things. Would you do extra tests like that, or it's let's just take the supplements?
You know, there's no good study to show that any fixed level will be helpful. You know, there's nothing to really aim for. So I would look at the overall picture, her age, her diet, you know, and then, you know, I will discuss the options of starting on the supplements, because the supplements are actually very safe to take. I don't give a very high dosage. They're very regular, you know, safe supplements to start taking. So I would usually suggest that they start if looking at the history.
So how long before an IVF cycle would you recommend they start this up? So would you, let's say if they were to take it a month later, would you start the IVF cycle, or would you like them to have it for a period of time?
Typically, you know, 1 to 2 months is fine. We can't wait too long also, because we don't know whether this is really going to help and the AMH will drop. So you know, some time is better than no time on the supplements, but I wouldn't wait too long either.
Understand. Okay, for these supplements, one more thing. I know a lot of ladies, they get very confused because obviously these supplements are for egg quality. So let's say after you treat the eggs and everything, should they still continue with these supplements, or basically they can stop, you know, like CoQ10 and things like that? Or do they need to take it even after they do embryo transfer?
So usually for my patients, after embryo transfer, I would then suggest that they switch over to the folic acid and prenatal supplements already. So things which are safe for the pregnancy.
I understand. So basically a changeover.
Yeah.
Okay. Somebody was asking us about duo stims. Okay. So in a nutshell, would you just explain what duo stims is? Because it's something that's very new and you don't really hear much about it in Singapore, right?
Yes. So duo stim is something I actually encourage patients to consider. So
Okay.
a dual stim protocol basically involves stimulating the patient twice in the same menstrual cycle. So in a traditional IVF cycle, you stimulate a patient from the start of a period, and then once her eggs are ready, we collect them.
Yeah.
And then, we either freeze the embryos or transfers, but that's one cycle. So
Okay.
with dual stim, after we collect the eggs, we give her 5 days of rest, and then we straight away stimulate again. So we are looking at 2 rounds of egg retrievals within one
cycle.
Yes.
Is there a chance that she could ovulate, or would there be medication to stop her from ovulating from her remaining eggs?
So under all these hormones, she won't be ovulating spontaneously. So once eggs are collected, the aim is to stimulate the small baby eggs which are activated during the first cycle, so that we can collect more in a shorter period of time. So I think that's the advantage, to be able to collect more eggs in a shorter period of time.
Interesting. In terms of, let's say, is there a standard, like, let's say, okay, I can only see that you have 2 small eggs. Let's not go for a dual stim. Is there a certain number of eggs that have to be remaining inside, or would you just recommend it for whoever?
Yeah, so that's a good question. Studies are still ongoing. So in my practice, if I see a good number coming up, then sometimes I will encourage patients to really consider it. But when I see very few, then I'll be more hesitant, because it can be very tiring to go for such a prolonged stimulation, and at the end of it, sometimes we get really good results. Suddenly lots of good eggs come up, but other times we don't get such good results. Sometimes we don't get many eggs, and sometimes eggs you collect are not so healthy. So it's a very long treatment process and very tiring physically on the lady. So instead of a dual stim, sometimes I would actually suggest have a break and then maybe do consecutive stims. So maybe
is this something that you would recommend, consecutive stims, or would you usually ask them to rest a month and then go on to a next IVF cycle?
So I decide based on the ultrasound scans. So sometimes after the collection, the period comes, I will do a scan, and then if I see lots of follicles, so I will suggest, why not we'll
go straight away.
Just go in straight away and try to get more eggs.
So it really depends.
I think that's the idea, to try to get more eggs in a shorter amount of time, so that we can focus on the embryo transfer, and the time to a healthy pregnancy will be hopefully shortened.
Understand. Somebody just asked, does dual stim actually increase the chances of OHSS?
I haven't seen that happen, because normally I offer dual stim in patients with low ovarian reserve.
True, right?
There's already fewer eggs, and at Mount E we do have special packages for those with low reserve, going on dual stim or consecutive stims.
Okay. Oh, that's very interesting. So special packages, you mean like basically like monetary packages, or?
A little bit, privileged pricing.
Understand. Oh, that's very interesting, because we've never heard of any clinic that has that before. So so keep that in mind, anybody who's looking for dual stims, special packages. Fantastic. Okay. One other question that we've had, which is very, very common. Okay. Day 3 embryos versus day 5 blasts. Okay. Does your clinic do day 3 embryos? If not, I mean, which one to you is still better?
Yes. So day 3 embryo transfers can be performed at the patient's request, but our modus operandi, our standard mode of operation, is actually with day 5 blastocysts.
Even if there's only 1 or 2 fertilized eggs?
That's right. So over here at Mount E, our embryologists have had over 20 years of experience with blastocyst culture. So we know that they are in very expert hands. And our experience and success rates with blastocysts have been very good. So usually, I'll tell patients standard treatment here would be just wait until the day 5 blastocyst forms and freeze those for use. Also, day 5 transfers are actually, if you think about it, more physiological, because at day 3, the embryo is still growing in the fallopian tube. They only reach the uterus endometrial cavity around day 5.
So that's another
So
good
when we
reason
transfer
why.
at day 5, it makes more sense, it's more in tune with nature, and there's less risk of hopefully ectopic pregnancy. So those are some advantages.
In terms of frozen transfers and fresh transfers, so just now I know you, I think you said that mainly you guys do fresh frozen transfers.
Frozen transfers.
So let's say if there was a patient who wanted fresh transfers, would that be possible, or would you still say go for frozen?
I would also consider it if the patient really wants it, and after showing her the statistics, if she still wants to go for a fresh, no problem, we can still do a fresh cycle. But normally there are certain things I would look for before doing a fresh cycle, and these will include the hormone levels on the day of the HCG trigger or the trigger shot. So if the progesterone level, for example, is very high, studies have shown that this affects the uterus lining. And if we do a transfer in that cycle, the success rates will be much lower. So that's one thing I look at, and I will also look at the endometrium itself. If there's any concern it is not so optimal looking, then I would also suggest to hold off.
I understand.
So there's certain
in
things.
terms of just now you mentioned progesterone blood test. Okay, one big thing that I realized that the difference between public hospitals and private clinics, I presume in your clinic as well, is that you guys do. How often do you do blood tests for like all the various things?
So we do blood tests, I think, unfortunately, quite often.
Okay, that's good.
Because we want to see how the eggs are growing and how the uterus lining is behaving. So progesterone levels I will also check after an embryo transfer. So in terms of
prior and after,
usually after for my case. So then I would personalize the luteal support. So if the progesterone levels are a bit low, I would add on injections and increase the progesterone levels.
I understand. Now, so that's something, I mean, just to our followers who are in public government hospitals, because I did it there and we never did any blood tests. So this is something that's very important, because sometimes whether you succeed or not is your progesterone level. And so it is very important to have these kind of blood tests, and which private clinics do give you. Okay, somebody was just asking, does a day 6 blastocyst have a lower success rate than a day 5 blastocyst?
That's an interesting question, but I think as long as the blastocyst is a good grade and classified accordingly by the embryologist, then it's still considered good grades.
So if it's a 6AA, it's still a good embryo, basically.
Yeah, exactly.
Okay, one more question somebody asked. Privilege pricing for dual stints, is it with Mount Elizabeth Fertility Center or basically your own clinic?
Mount Elizabeth Fertility Center.
Okay, all right, that's the answer. All right, okay, okay, let's see. What is your advice on how to optimize the chance of implantation on the first few days after FET? So progesterone levels is probably one of them. That's
right, yeah. So progesterone levels, and then other things like having good rest, eating healthy diet, taking your folic acid and supplements. I think those are the main things. Yeah, I don't believe that you need to be bed bound. Yeah, and not moving at all. So I think light activity that should be sufficient.
Okay, just no like going to the gym or things like that, right?
Obviously. Exactly. No headstands.
Okay. Yoga. Okay, so I ask, what is a normal progesterone level? Is it the same for everybody before and after a transfer? Is there like a standard level, or does it vary between people?
Yes. So again, studies are being done. The research is still ongoing. A lot of the progesterone we give is actually through the vaginal route. So in theory,
right?
In theory, that should be sufficient. But at the same time, the serum blood test does give another indicator. Some studies have shown that if the levels are not high, it can lead to poorer, results.
Understand.
So for me, I do look for a certain level, but it's still, the research is still ongoing, and there's no hard and fast kind of rule.
Like a standard, basically. You still have to go for your tests, and then the doctor will give you the advice.
Assess according to the whole scenario,
Yeah. Okay. Somebody asked, what are your thoughts on intralipid? Honestly, I don't know what intralipid is. I don't know whether you'd be able to explain what that is. And then, so what are your thoughts on it, and under what circumstances would you recommend it?
Okay, yeah, so intralipid is also something that I offer in my clinic. It is actually a mixture of soya bean oil, egg yolk, glycerin, and some water. So
Interesting. Okay.
yes, so intralipid therapy has been shown in some studies to modulate the natural killer cell activity and
Mm-hmm.
improve the implantation rates for patients, especially those who have had a history of recurrent implantation failure or recurrent
Yep.
miscarriage.
Yep.
So
So
basically,
are
I
they
would offer.
injections that you take?
They are intravenous infusions.
And then when would you
So
take this injection?
So, for example, in my clinic, where I
Mm-hmm.
offer it, I do offer it to patients here. So we'll set a little drip into your
Yeah.
vein,
So,
and then we'll
okay.
run the lipid in for about half an hour. So it takes about half
Okay.
an hour. Yeah. So we just run maybe 100 mils in. So it's actually very safe. It's a safe
Okay.
product. It's given to patients in hospital as a form of nutritional support and source of calories if they are unable to eat. So it's a very, very safe product. Side effects are quite minimal. Some patients get some stomach upset, nausea. So actually, overall, on balance, I find that it may be beneficial to offer patients this therapy if they have a history of recurrent miscarriages, implantation failure, or nowadays I do check the natural killer cell activity levels also. So if
Which
the
is
NK
very
cell
important.
activity level is a bit on the high side,
Uh-huh.
then I would discuss it with them and start the lipid therapy.
So it would be before a frozen transfer?
Typically, yes. Typically,
So
we
after
do it
stims, before a transfer.
correct, yes, before a transfer. And then once they're pregnant, we may carry on for another few rounds every 2 to 3 weeks.
Ah,
Mm.
how interesting. I've never known that. Okay, interesting.
Mhm.
Just now you also said the killer cells, right? Just
Mhm.
now.
Yes.
When would you recommend doing that test? After repeated miscarriages or what
Yes. So
situation?
normally I would offer tests, a bunch of tests to check for immune issues and blood clotting problems in
Yep.
patients more with recurrent miscarriage and previous history of failed implantation despite using nice embryos and transferring into a nice uterus. So
Yep.
I would definitely offer these tests and checks for such patients. But then we are getting lots of older age group patients also who don't really have the time, luxury of time
To
to
try
keep
and try and try.
trying. Yeah, so
Yep.
sometimes I would offer these tests earlier to just,
Okay.
make sure there's no other problem we are missing out before doing the transfer.
So if somebody does find out that they have a problem,
Mm.
can something be done to help them?
So, for example, if the natural killer cell activity is very high, then
Yep.
we would offer intralipid therapy, or if there's a blood clotting issue, we would be offering aspirin blood thinners as well as injections, Clexane injections to improve implantation. I sometimes also work with rheumatologists to make
Yes.
sure that we are providing the right treatment.
Understand. In terms of, let's say, a patient coming to you has been trying for, let's say, a year and everything,
Mm.
how many cycles would you actually advise them to try, let's say, for IUI, and then subsequently, how many times would they have to fail before you said, okay, let's go on to IVF?
A ballpark figure for I would say would be maybe 3 or 4 rounds uh,
Okay.
before moving on. Because if it keeps failing, there might be some issue with fertilization,
Yeah.
in which case IUI is not going to work. But the
Understand.
actual number really will depend on
Depends on the person.
the patient and the husband. So the patient's age, her ovarian reserve,
Yeah.
and also the husband's sperm. Before IUI, what's the motile count? Is it worth keep trying, or whether
Yeah.
it's better to just move on to IVF? These have to be discussed.
Correct. And then in terms of IVF, how many, is
Mm.
there a ballpark figure that you would say, okay, after, because the hardest thing is to tell somebody, okay, I think it's not working, I think it's
Mm.
time to
Mm.
consider something else, donor eggs,
Mm.
things like that. I mean, was there a ballpark figure that you would say, okay, or is it a case by case basis?
I have to say it will have to be a case by case basis. So in the past, there used to be a limit, but now the Ministry of Health has removed this limit, and there's no even age limit anymore. So
Yes,
it
yes,
can be
yes.
quite difficult for patients to decide when to stop. But
Correct.
in ladies with a low reserve, every cycle is different, and
Yes.
every cycle is unique. And because they had poor results from one, you can see from my case studies also, it doesn't mean the next round will be equally as bad, because sometimes the next cycle may be better and give us healthier eggs and better outcomes. So I think as long as the ovarian function is healthy and the patient is you know, willing to accept the risk and stress, I think then
That goes with it.
we could carry
in terms of, let's say, IVF cycles, from one cycle to the next cycle, would you do a lot of changes in medication, whether it's Gonal, Mandifor, and this and that? Or is it basically you'd see how they react to the first cycle first?
Yes, I would see how they reacted first, and then also our egg retrieval results, how healthy the eggs were, and how many embryos and blastocysts we got from the eggs.
Understand. Okay, somebody just asked, I understand that Mount Elizabeth Fertility Center labs have a new technology for ICSI for better sperm selection. Is it IMSI or something? I can't remember. But she said there is some new technology. This has to be recommended by the doctor beforehand, and the lab will do this, and there are additional charges. Would you know?
So I think the question might be referring to IMSI, morphologically selected sperm. So not all labs have this. So basically, this is another device that can help to select healthy sperm, and the basis is the use of a very high-powered microscope, so that the embryologist can see the sperm in
bigger,
greater magnification. So that's the idea.
Okay, so one question to do that as well. Who decides whether it's ICSI, MACS, or IMSI? Does the patient decide, or does the doctor recommend?
It's usually doctors or embryologist recommendation.
Okay.
Yeah, so we work closely with the embryologist to see what might be helpful. But some patients have already read up and may also request, which we're open to also.
Understand. For MACS, somebody was also asking, is it a significantly more expensive step to undertake when undergoing the usual IVF? So ICSI and MACS, is there a big price difference?
It is an additional few $100.
Okay.
500.
So much already. Okay, all right. Okay, fantastic. A few more questions. So somebody was asking, these are personal related questions. So there's this patient who basically has a recurring bacterial vaginosis. Will this have an effect on an IVF procedure?
So I think any infection detected should be treated ideally before any IVF procedure. So if a patient had symptoms, I would also test and treat before any embryo transfer. If there's any inflammation at the vaginal area, it might also affect the cervix and lead to inflammation of the endometrium, so that's not ideal. So it's best to treat any infection beforehand.
So fix it all beforehand. Okay, somebody's also asking, basically, 30-year-old woman, multiple diagnoses like endometriosis and adenomyosis. So do you do surgery, or what would you do to help fix these problems before an IVF procedure?
So I would also offer surgery. Again, it depends on the patient's condition. So we have to assess her scan results, her cancer markers. So, we don't want to miss a cancer also. So that's the main thing. Yeah, she must be in good health. If it's likely to be endometriosis, it depends on how severe it is. Sometimes, in order to preserve her egg count, we want to avoid surgery. So we would, sometimes with small cysts, just still carry on with egg collection first. And then assess the situation. Yeah, so if we have some nice embryos, then perhaps it'd be a good time then to clear up the endometriosis and treat the adenomyosis before the embryo transfer. But in some cases, surgery may be necessary first beforehand. If there's any risk of any cancerous cells or changes, then surgery would be wise first.
And then obviously after surgery, you would suggest how fast they can do a IVF cycle after that, right? They would obviously have to wait a certain
That's right. So maybe 1 or 2 months of hormonal regulation first.
Understand. Okay, somebody was talking about, transferring 1 or 2 embryos. Some doctors are very big on transferring 2, and some say just do 1. What is your usual practice?
So you can see from our statistics earlier, actually most of our transfers are based on single blastocyst transfers. So normally I would also encourage patients to transfer just one blastocyst rather than two, because our blastocyst implantation success rates are already quite high. So if we transfer two blastocysts, the success rates may not increase by that much, yeah, but by maybe a few percentage points. But then there is this risk of twins. So from the medical point of view, twin pregnancy is always considered a higher risk pregnancy, and it's definitely true that they have a higher risk of premature labor and delivery. If babies do come out too early, they end up in NICU, and that's a lot of complications involved potentially for early twin deliveries. So we try to avoid twins as much as possible. However, of course, some patients still
You do get
insist,
some people who,
and they want to try and for twins, so we still can transfer up to a maximum of 2 blastocysts.
Okay. We had this question. Okay, how would you diagnose FSH, follicular polymorphism, also known as empty egg syndrome? It seems to be getting more and more common these days, but how would you diagnose it, and then what would you help with that?
Yes. So true empty egg syndrome or empty follicle syndrome is actually very rare. I think from records it actually occurs in less than 1% of cases. So that's true empty follicle syndrome. So this is diagnosed on the basis of normally growing follicles with normally rising estradiol levels, appropriate trigger medication, but no eggs are retrieved at the egg level. But this is actually quite rare. So most of the time, true empty follicle syndrome doesn't happen. It could be related to a drug issue, or maybe sometimes retain eggs within the follicles. So a drug issue is more common. It can occur because of a wrong trigger medication, or inappropriate trigger, or low dose trigger that wasn't sufficient for the patient, or sometimes the wrong timing. So sometimes the trigger was given at the wrong time for the patient. So that results in follicles yielding no eggs. For other patients, I do perform follicle flushing. So for some women, I do find that the eggs tend to be retained within the follicle. So in a typical egg retrieval process, we slide a needle in, and then we apply suction and aspirate the egg. But if the aspirate doesn't contain eggs, then I may flush the follicle again and
But how do we know whether there's an egg or not? Will you be able to see it, or how?
Yes. So right after the eggs have been aspirated, the embryologist will check for us under the microscope.
Straight away?
Straight away. So it's an ongoing process. So I'll aspirate the egg, and then I'll pass it to my embryologist. She'll check and tell us, is there an egg found, or are they just cells? So we'll just keep flushing a few more times until sometimes the egg is found in a subsequent flush. But sometimes, there really is no egg. So unfortunately, as women get older, there is a higher risk that some of the follicles may truly be empty. But, I would look at, the trigger dosage, medication, and consider flushing the follicles, a few times before really saying that this lady has empty eggs.
So wow, it's very different from, again, just to let followers, it's very, very different from like a government hospital where they will just basically retrieve everything in one go and then send it to the embryologist, and then basically they will check, okay, how many eggs you have. Whereas, as Dr. Kelly said, they will do it one by one, right?
That's right.
Yeah, fantastic. Okay, in terms of, let's say, a lady who has normal AMH, okay, both cycles only yielded 3 to 4 eggs. Okay, is there any test that you do? Would you change? She's been on both Menipure and Gonal. Okay, so is there something that you would change, or how would you basically help?
So yes, I would have to look at the treatment protocol, and then I'll have to look at her response, her follicle chart, see how they grew. So we will have to relook at the treatment protocol, see if we need to add on other hormones and change the trigger shot for her. And again, I would consider doing follicle flushing in such cases. Try to increase the egg yield. Perhaps the eggs are being retained for some reason. In some women, the eggs are more sticky. They tend to remain in the follicle. So that's another important aspect. And again, I would encourage her, and I would say that, if your ovaries are still quite healthy and the ovarian function is still reasonable, every cycle is different. So perhaps,
Yes.
there'll be
Keep trying.
another better, healthier cycle.
In terms of frozen transfers, do you recommend medicated or a natural cycle transfer?
So that's also a very interesting question. I would normally offer natural cycles to patients who've had a previous pregnancy, spontaneous natural pregnancy, and I know her uterus is capable of, maintaining a healthy pregnancy. Whereas for those who have never been pregnant before, normally I would suggest a medicated cycle. But I'm actually open to both methods.
So it's really a case-by-case basis. Okay.
That's right.
Okay, somebody said, what would you suggest for unexplained infertility? I guess more tests, right?
That's right. So again, how long have they been trying? Have they gone through the 3-4 rounds of IUI? Is the egg reserve still good enough to wait, or should they be looking at IVF earlier?
In terms of failed IUIs, would you recommend next cycle straight away, or is it dependent on follicles again?
It depends on the follicles, yes. So if she fails the IUI, the period comes and everything looks good, no cysts are seen, then potentially I'll be happy to start another cycle.
Okay, so similar to IVF, right?
Exactly.
Yeah. Okay. Let me see. Is there any more questions? So many questions coming through. Okay. Would you recommend IUI to patients who went through fibroid removal surgery, or do you think it's better that she goes straight to IVF?
It depends on whether the tubes are healthy, fallopian tubes, and also again her age and other factors.
Understand. Is there a reason as to why? Okay. So do you know? Let's say if somebody goes for a scan and they have a functional cyst or follicular cyst. Okay. Is it better to basically rest that cycle, or under what circumstances would you say, well, let's go ahead?
It depends on how big the cyst is. If the cysts are less than 1 cm and her hormone levels are healthy, depending on the patient's circumstances, sometimes there's no perfect timing, so we may still go ahead and try. But ideally, I would prefer not to see any cysts at the start of any stimulation cycle.
Yes, understand. Okay, somebody asked, is MACS better for severe OAT as compared to ICSI? What's OAT? I'm also not sure what OAT is.
Is MACS better than?
Is MACS better for severe OAT as compared to ICSI?
Okay, so actually, ICSI is ultimately what is performed to fertilize the egg. So MACS is just an additional step to selecting, to preparing the sperm for sperm selection. Yeah,
so basically you pay for an extra step.
It's an extra step, yeah. So to clean up the sperm, remove the abnormal ones, so the more healthy ones are filtered through, and these are the ones that are chosen by the embryologist. So it makes it easier for the embryologist to pick up the most healthy sperm for the ICSI process. So ultimately, we want to choose the best sperm to do the ICSI.
Okay, 2 last questions. One, TCM, acupuncture, do you recommend it?
Yes, actually I do. Okay. So I do recommend acupuncture because I see that it can help some patients. So especially those with low reserve and poor outcomes from previous cycles. I think acupuncture on its own may stimulate circulation changes and blood flow to the uterus and ovaries. So as long as the patient doesn't feel too stressed about it and they actually feel relaxed doing acupuncture and feel good about it, then I think it's worthwhile exploring. But if they find it too stressful, they don't like the idea, that it's fine. I don't push it.
But in terms of how about TCM, in terms of how about medication, Chinese medication?
Exactly. So that's what I was going to say. With oral, herbal medication, on the other hand, I think we have to be careful because sometimes they have hormonal effects which we can't quantify. So I find that sometimes, we may get, cysts forming and so on. So I think with the herbal medicine, we have to be a bit more careful.
Understand. Okay, last question. I think this is a question that a lot of people will have asked you. How long after their second dose of vaccinations can they start a cycle? Oh, do you recommend if somebody's going through IVF, should they go for the vaccinations?
Yes, I think so. I think now with the COVID situation, the government is really pushing everyone to get the vaccine as much as possible. So, you know, we have to follow the Ministry of Health guidelines, and we also recommend the vaccination. So after your second dose, I would say wait 1 to 2 weeks. Once you're feeling well, then I would say you can go ahead with the stimulation. The main concern with the vaccination is really the side effects. So sometimes the vaccine can cause aches and pains, low-grade fever. So that's not ideal if you're going through a lot of hormone injections to feel unwell during this time. It will just add to the stress of the situation. So best to make sure you're fit and well before you embark on the cycle.
Okay, fantastic. Okay, I know somebody did ask about IVF pricing. You can call Dr. Kelly's clinic. Okay, so let's say if they want to make an appointment with you, what's the best way to do it? And can they just call your clinic?
Of course, yes. Just reach out to us. We have a website, so you can find it on our website or just try to give us a call.
What's the name of your clinic? Is there, or just Mount Elizabeth Fertility Center, or?
It's my personal clinic is Health and Fertility Center for Women. And the lab I work closely with is Mount Elizabeth Fertility Center, which is the lab based in Mount E.
One more question. Do you do deliveries as well? Is it a whole thing, or do you only focus on fertility?
Yes, so I do also offer a delivery service here at Mount Elizabeth Orchard Hospital.
So it's a whole thing. All right. Thank you so much. You've answered so many questions. I think this is probably one of the most questions we've answered in a session. And I'm sure that we've provided a lot of information. You're the first lady doctor to come on.
Oh, that's great.
With us. And we've always had a lot of ladies who go, is there a lady doctor that can come and talk to us? So you're the first one. And really thank you so much.
Thank you, Kim. Thank you, Kim, for being such a wonderful host. Thank you.
No problem. Thank you so much. Okay, so anybody who wants to make an appointment with Dr. Kelly, you can go to our website and I'll call a clinic for an appointment. All right. Thank you. Good night, everybody, and have a nice weekend ahead. All right. Thank you, Dr. Kelly.
Thanks,
Bye.
Kim. Bye-bye.